Inflammatory bowel disease, or IBD, is a broad category of chronic gastrointestinal inflammation. In clinical settings, the two primary subtypes of IBD are frequently confused, despite having entirely distinct pathological signatures. Ulcerative colitis is strictly confined to the colon and rectum. Inflammation originates in the distal rectum and continuously marches upward into the proximal colon without skipping segments. This distinguishes it from Crohn's disease, shown right, which presents anywhere from mouth to anus as fragmented skip lesions. Ulcerative colitis is also restricted by depth. The inflammatory damage is isolated to the innermost histological layer of the intestinal wall, known as the mucosa. These specific histological and anatomical borders create a predictable clinical workspace. By defining exactly where the disease resides, we can begin to deduce its impact on the rest of the body. Despite knowing exactly where it occurs, the exact definitive trigger for ulcerative colitis remains idiopathic. The disease manifests through a complex interplay of variables. A patient often carries a dormant genetic predisposition until it meets an environmental trigger, such as chronic stress or certain dietary factors. These factors act as catalysts. They confuse the immune system, causing it to incorrectly identify the healthy colonic mucosa as an invasive threat. This results in a state of severe immune dysregulation. The body mounts a persistent, aggressive inflammatory response that it cannot turn off on its own. UC functions as a self-sustaining autoimmune feedback loop. Unlike a simple infection, it requires systematic long-term interception rather than a short course of targeted medication. To understand how this autoimmune loop damages the body, we have to scale down from the macroscopic colon and look at the microscopic cellular architecture of the mucosal lining. Notice the rapid influx of highly aggressive immune cells, improperly swarming into an otherwise clear and healthy mucosal layer of the lower GI tract. Here we see a cross-section of that mucosal barrier. The localized inflammation directly attacks and destroys the highly organized epithelial cells that form the colon's protective inner wall. Stripping away this protective layer leaves the raw underlying tissue completely exposed. This mechanical breakdown creates a caved-in defect in the tissue, which we identify as a macroscopic mucosal ulcer. As the tissue structure fails, we see the defining pathological hallmark of the disease, the crypt abscess. The immune cells accumulate and become tightly trapped in the deeper U-shaped glandular crypts right beneath the ulcer. Over time, this prolonged cycle of cellular destruction and trapped inflammation degrades the structural architecture of the colonic walls. This microscopic destruction of the epithelial barrier is the exact mechanical engine driving the severe clinical symptoms we observe in patients. With raw, bleeding mucosal ulcers now lining the colon, the most common patient complaint makes perfect anatomical sense: persistent, bloody diarrhea. The severe localized inflammation across the rectal and colonic walls also induces intense abdominal cramping. This is accompanied by tenesmus, a continuous, urgent sensation of needing to defecate, even when the bowels are completely empty. Moving beyond waste transport, the colon has a critical secondary function: the absorption of water and nutrients. The widespread destruction of the mucosal surface severely impairs this capability. This drop in absorption leads to rapid weight loss and profound fatigue. The body starves for nutrients while running a persistent fever, driven by the systemic inflammatory state. The danger compounds when you combine the chronic blood loss from the open ulcers with the colon's inability to absorb key vitamins, specifically iron and folic acid. This dual threat, bleeding out resources while failing to take in replacements, frequently results in systemic anemia, a dangerous complication. The clinical presentation of ulcerative colitis is a direct, logical reflection of the underlying damage. It is a cascading failure of a structurally compromised and actively bleeding mucosal barrier. Because bloody diarrhea and abdominal pain overlap with many other gastrointestinal issues, clinicians must visually and histologically prove the presence of the disease. The gold standard diagnostic tool is a colonoscopy. This procedure allows the physician to directly observe the continuous inflammation and macroscopic ulcers mapping the colonic wall. Visual confirmation is only half the process. During the colonoscopy, the physician harvests tissue samples for a biopsy, looking for the definitive microscopic proof we discussed earlier, the crypt abscesses. Supplemental blood panels are then drawn to quantify systemic inflammatory markers and assess the severity of any underlying anemia. Finally, stool culture tests are required to definitively rule out bacterial or parasitic infections that can mimic the symptoms of inflammatory bowel disease. An accurate diagnosis requires marrying the macroscopic visual evidence of continuous ulceration with the microscopic histological proof of immune infiltration. Once diagnosed, medical management centers on a single strategy, halting the abnormal immune cascade before irreversible structural damage occurs. We illustrate this approach as a pharmacological ladder. Step 1, used for mild to moderate cases, relies on aminosalicylates. These are localized anti-inflammatory drugs that act directly on the mucosal surface of the GI tract. If a patient experiences an acute flare, we move up to Step 2, corticosteroids. These act as a blunt force tool to rapidly suppress systemic inflammation and quiet the entire immune response. For chronic, refractory cases that don't respond well, we escalate to Step 3, immunomodulators. These drugs actively suppress the patient's hyperactive immune system on a long-term basis. Finally, we have biologic therapies. These are precision-engineered molecules designed to target and neutralize the specific inflammatory proteins that are actively driving the disease cascade. The pharmacological ladder is designed to scale its targeted aggression to match the severity of the patient's immune dysregulation. However, there is a reality of medical failure. When the pharmacological ladder is exhausted and fails to control the cascade, chronic inflammation triggers a catastrophic structural breakdown of the large intestine. Look at this clinical animation. This demonstrates the most immediate life-threatening complication, toxic megacolon. Trapped gases and severe inflammation cause the colon to rapidly distend and lose its muscle tone. This creates two fatal risks: overwhelming systemic toxicity and a catastrophic bowel perforation where the stretched, thinned intestinal wall simply ruptures. Even if a patient avoids an acute rupture, decades of constant cellular destruction and rapid regeneration in the mucosa increase the risk of developing colorectal cancer. When the risks outweigh the benefits of keeping the organ, we arrive at the final, definitive medical intervention, a colectomy, which is the complete surgical removal of the colon and rectum. Because ulcerative colitis is strictly bound to the mucosal architecture of the large intestine, removing the colon and rectum eliminates the tissue bed where the disease occurs. In this context, the anatomical boundaries that define the disease also dictate its definitive cure.